All right, go ahead.
There was only one of the quizzes online for last week. Was that supposed to happen?
No,
Because
it was not supposed to happen. And when I logged in today to look at your grades, when I logged in this morning to look and see how you guys did, um, I realized that the other one was not up. And so I opened it as of 9 o'clock this morning, and it'll close at midnight tomorrow. So
Okay.
um, if you notice that happening in the future, if one of you could send me a message, that would be wonderful so that I can fix that, because we can't fall behind if you guys want to finish your certifications. So,
Okay.
okay,
Sounds good. Sorry about that.
that's all right. Thank you. I appreciate you asking about it this morning. Hi, Cameron.
Hello.
How are you this morning?
I'm good. How are you?
I'm okay. Welcome to Monday.
Yeah.
I don't know who else is coming, but I'm gonna give them. I'll give them a couple more minutes, and then we'll start without them if they decide not to come.
Okay.
All right. Well, it looks like there are 3 of you here at 9:05. So let's, I guess let's talk about chapter 27. I need to show my screen, make you bigger, share my screen, because I already have that PowerPoint presentation pulled up. Okay. These PowerPoints are available to you on Schoology already if you choose to use them. They're in resources under PowerPoint presentations, and so all of this information is available to you if you would like to use them. I wanted to talk about, I'm going to unmute you guys so that hopefully we can all maybe talk at the same time so that I can almost act like I'm having a conversation. Trey is already unmuted.
Unmuted.
Unmuted. And not only are you unmuted, but you are not wearing a cat mask.
Yes, I am not.
How was your Easter? All of you.
Good. I made an egg. Do you want to see the egg?
Sure. Oh, very cute. Very cute. Nicely done.
Thank you. So that's my big accomplishment. Yeah.
My big accomplishment yesterday was that I actually managed to get my 10,000 steps in. It didn't happen until late yesterday evening, but I did it. So,
Awesome.
Yeah.
Yeah, I've probably done a collective of 3 steps total.
I've done pretty well. I think I think maybe 5 out of the 7 days last week, I probably got my 10,000 steps. Yesterday, yep. Saturday, yep. Friday, I did 18,438 steps. Thursday, I didn't. I only got 8,800 steps. Wednesday, I got 9,600 steps.
Do you just pace around or do you go on
No,
a
I
walk?
go on a walk or a run or something. Tuesday, I got 15,000 steps. Monday, I got 11,000 steps. And last Sunday, I got 8,000 steps. So if I go Monday to Sunday, I got 10,000 steps in 5 out of 7 days. That's not bad.
Yeah. That's better than probably most people right now.
I'm trying to make sure that I spend as much time outside as I can, because I can't go to the softball fields and I'm going bonkers. So, okay. So we have about 50 minutes to talk about face and neck injuries. And the reason why face and neck injuries are so severe. So we're just going to go through this as quickly as we can. Your face and your neck are vulnerable to injury because they're basically unprotected, right? For most of the other organs and the other structures in your body, they have some type of protection, but your face is the skin around your face is very, very vascular, and The structures that make up your face are structures that are near the surface of the body. So your orbit of your eye is right at the surface of your body. Your nose, your mouth, those are all very close to the surface of your body. And so those injuries to your face can be serious because they can cause problems with your airway. And when we have problems with our airway, then we have problems with, well, life, right? Because perfusion is always the answer, and in order to maintain perfusion, we have to have an airway. Some injuries can be life-threatening, particularly to your neck, not necessarily to the back of your neck, to your C-spine, but to the part of your neck where your airway is at and where your veins and arteries are at. If you have an injury that is open to a vein or an artery, you can have air get in that injury, and if air gets in that injury, it can cause, well, an air embolism. If it causes an air embolism, that can travel to the heart and prevent your heart from beating appropriately. Let's see how this works here. All right, so the next thing that this slideshow wants you to cover is the structures of your head. Your cranium covers your brain. You all should know what the bones in your head are. We've covered that a couple of times. Remember in your temporal area that you can feel your superficial temporal pulse right there, right? Your face is composed of your eyes, ears, nose, mouth, cheeks. Trey, did you find your pulse?
Yes, I'm alive. Still
Believe it or
beating.
not. And the face is made up of the nasal bone, 2 zygomas, 2 maxilla, and a mandible. Your orbit is made of the frontal bone, the zygoma, the maxilla, and the nasal bone, and the orbit is designed to protect your eye from injury. So if you'll notice, if you put your hands right over the front of your eyes right here, your eyelid will, like, keep your hands flat, put your hands over there, your eyelid will touch the surface of your hands, but anything that's flat will not get to your eye, and that's the way that it's designed. It's designed to protect your eye.
Nice.
Yeah. The nose is mostly cartilage. The ear is all cartilage. Behind the opening of the ear is your mastoid process. We've talked about your mastoid process before because when you hold C-spine, your mastoid process is the process that your fingers go on. These fingers right here, it's the process that your fingers go on behind the ear to help hold the head and the C-spine in place. Your neck has your cervical spine in it. It has your trachea, and it has the trachea where it splits into the larynx and the esophagus. Your carotid arteries are on either side of the trachea. Your jugular veins are in that area as well. All right, this is all structure stuff. Okay, so injuries of the face and neck, I just mentioned this to you, but injuries of the face and neck can often lead to a partial or complete obstruction of the upper airway. When you've seen people in movies or TV shows where they cut a hole in the cricoid cartilage and they create a cricothyrotomy right there so that people can breathe, it's because they've got an upper airway obstruction and they need to be able to get air past that obstruction. So let me go back up here for a second. Can you guys see this? Is this big enough on your screen that you can see it?
Mm-hmm.
Okay, so right here in the middle of your, like right below your larynx and your cricoid cartilage, so your thyroid cartilage and your cricoid cartilage, in the middle is a soft spot. And you can feel in your own larynx, you can feel where that soft spot is at. If you go just below the protrusion of your larynx, you can feel that soft spot. And so when people do a cricothyrotomy, it's right there, in that soft spot in between the thyroid cartilage and the cricoid cartilage.
It's kind of small.
It's pretty small, yeah. So they use like a pen. You've seen the shows or heard of the shows where they take a scalpel or a knife and they cut into there and then they stick a pen in that hole.
Mm-hmm.
Yeah, it's only about that big. It's only about the size of your pinky. It's not very large at all. However, if you don't have any other way to get an airway, that's a way to do it.
So as EMTs, are we allowed to do that?
No, that doesn't mean you won't see it. It just means that you can't do it. Okay, so the face and the neck are very, very vascular, as we already discussed, and injuries bleed a lot. So it might seem like the injury may seem more severe simply due to the amount of blood that is coming out of the injury itself. Let's see. All of this scene size up stuff. All right, so your primary assessment should be focused on identifying and managing life-threatening concerns, and your threats to your ABCs have to be treated immediately. What that means for you is that it does have a caveat here. If there's a life-threatening external hemorrhage, it should be addressed before airway and breathing. Absolutely. You cannot have appropriate perfusion without appropriate circulation, without appropriate breathing, without an appropriate airway. Shock will set in sooner if there is no blood circulating than it will if there is no air going in and out, because your body holds on to some of the oxygen and it will still circulate even if you're not actively taking in air. If as soon as that blood stops moving, it can't circulate. So if there's a life-threatening hemorrhage, absolutely take care of that first. Okay, so we're going to treat soft tissue injuries to the face and the neck basically the same as we would anywhere else on the body. We're going to do ABCs and treat their life threats first. Make sure we have appropriate precautions, or we've taken appropriate precautions. And if we suspect that they have a cervical spine injury, don't move their neck, which, you know, seems like it should make sense. We're going to control bleeding by applying direct manual pressure with a dry, sterile dressing. Don't apply excessive pressure if you think that if you believe that there's a skull fracture underneath your injury. Oh, you guys, you know what? I need to make myself a note because I have to do you guys need to do your egg skull fractures. You can post those on Schoology.
Egg skull fractures.
Yes, they're so much fun, and I love doing them in class because kids have a lot of fun with them, but obviously, you know,
Don't really have a class.
yeah.
So with those skull fractures, are they just, if you suspect them, it's just same as a normal fracture where
You can't really splint a skull fracture.
Mhm.
And depending on the type of skull fracture, there's linear, depressed, basilar, and I think this is actually next chapter. I think it's chapter 28 when they get into head and spine injuries. But if you believe that your patient has a basilar skull fracture, that's one of the contraindications to the use of a nasopharyngeal airway. There are specific signs or symptoms of basilar skull fractures. And depressed skull fractures that have brain matter hanging out are typically a sign that the injuries are not compatible with life. Not always, but typically. We are going to make sure that we control bleeding, especially around the mouth, and check and see if there's bleeding inside the mouth, because we need to make sure that we're keeping their airway clean. So if we have to pull teeth out or we have to suction the airway clear, we need to make sure that we take care of that. Sometimes avulsions How are avulsions different than amputations?
Avulsions still have part of it on.
Do you think that's true? Read this
No, because you can
description
have
of
a
an
complete
avulsion here.
avulsion.
Yep. So what's the difference between an avulsion and an amputation?
You could put an avulsion back.
You can often put an amputation back too. The real difference between an avulsion and an amputation is that an avulsion is simply skin. It's the layers of the skin. If you have an amputation, other structures are included in that injury. So bones or cartilage or something else is included in that injury, and that changes it from being an avulsion to being an amputation. Okay? If you find pieces of avulsed skin, wrap them in a sterile dressing, put them in a plastic bag, keep them cool, but don't put them directly on ice because ice will cause frostbite to those pieces of skin. If it's still attached, put it back in its spot and hold it in place with a dry sterile dressing. If you have an eye injury, you need to be fairly careful with those. Particularly if you have a penetrating injury, you're going to want to stabilize. You don't want to remove anything that's penetrating. So you're going to want to stabilize whatever the penetrating item is, wrap it up, and then cover the other eye because, I don't know if you guys know this or not, but eyes tend to move in the same directions. So if you leave one eye uncovered, then you run the risk of your patient trying to look at things and moving the eye that has the penetration or the impalement in it, which then causes or can cause more severity or a worse injury than what they originally had.
I learned this yesterday, but the cornea is apparently the quickest healing part of the body. Because the tongue is supposed to be the quickest external part of the body that heals. But apparently the cornea, since it doesn't have vascular blood flow, heals the quickest or something.
That's why I would have thought that it didn't heal the quickest because it doesn't have vascular blood flow.
Yeah,
So let me just double check that because what part of the body heals the fastest? What it says, according to Shoreline Vision, the cornea is the only part of a human body that has no blood supply. It gets oxygen directly through the air. The cornea is the fastest healing tissue in the human body. Thus, most corneal abrasions will heal within 24 to 46 hours. Interesting. I would have thought that that would not be the case.
yeah.
There's Morgan. Hi, I found you, Morgan. By the way, you guys are so silly. Why are we looking at foreheads?
It's really early.
It's 9:30. And not only that, but I don't mind seeing your faces.
But I mind my face being on YouTube when I look like a gremlin.
Show up on YouTube? I thought it just showed up when I was looking, like what I was recording. Because like right now, my screen share is my PowerPoint presentation. It's not you. Right? I don't know. Somebody can go look at last week's YouTube lecture or Zoom video and see what happens.
Yeah, I'm on there as much as you are. Just from the amount of that I talk.
Well, that's okay because it's better than not having any interaction at all, I think. Okay, so when we need to flush the eye, and I wish that maybe the next one will show you, when we need to flush the eye out, it is very helpful to be able to flush with sterile saline and to use a nasal cannula. If you lay your patient on their back and you put both, you know how the nasal cannula has those two prongs like this, right? If you put a prong on both sides of the nose and you take sterile saline and you squeeze it in the end of the nasal cannula, it will run right inside, right down the sides of their nose like this, and then right out the sides of their eye. Really, really cool. Not super comfortable, but very, very cool, and way easier to use than trying to get somebody to sit still to flush their eye one at a time. It's pretty cool. Flush from the nose side toward the outside to avoid flushing material in the other eye. This is a picture of what I was just talking about with a nasal cannula. Gentle irrigation, it might not wash out things that are stuck to the cornea or lying under the upper eyelid. So if they continue to have problems or continue to have complaints about it feels like there's something in there that's scratching them or rubbing their eye or something like that, you should ask them to go be seen by an ophthalmologist or in the emergency room. We just talked about this. If you have an impaled object, you need to bandage it in place to support it and then cover both eyes. These are different examples of eye washing. This one is the one that I just talked to you about with the nasal cannula. Obviously, all of these, hi Ashton, look at how beautiful you are this morning. Obviously, all of these are acceptable. Some of them just work easier than others. If your patient is having difficulty breathing, this is not going to be a position that they want to be in. They're not going to want to lay down in order for you to irrigate their eyes with the nasal cannula. So you're going to have to be a little bit more creative.
So with the bottom right one, are they just shoving their face into a bucket full of saline solution?
No, they're actually using a, hi Morgan, you look wonderful too. It's so good to see you. They're actually using a, like a syringe or a squirt bottle or something to try and flush it out. This one and this one are the best because they provide a constant stream. This one provides a constant stream to one eye. This one provides a constant stream to both eyes. This says, this is for a burn, but right here, this is what you were just talking about, Trey. You can immerse their face in a large pan or basin of water and rapidly blink the affected eyelid. However, the problem with that is that as soon as you do that, you've then contaminated the water that they're using to flush their eye with. And we don't want to do that because we don't want that same burn or the same chemical to get back in their eye. So we need to choose something else if we have any other way to do it. If they have a chemical burn, we're going to flush their eyes. If they have a thermal burn, we are not going to flush their eyes at all, but we are going to apply a moist sterile dressing to cover both eyes. Which is interesting to me because we don't apply moist dressing over any other burns, right? Removing contact lenses. All right, nosebleeds. Nosebleeds are quite common. They happen to a lot of people on a daily basis. It says one of the most common causes of nosebleeds is digital trauma. What's digital trauma?
Trauma that is caused by the fingers.
Yeah, they're picking their noses.
Noise.
Yeah. Anterior nosebleeds usually originate from the area of the septum and they bleed fairly slowly. Posterior nosebleeds are more severe and they often cause blood to drain down in the throat. Now, probably when you were a child, you were told that people should lean their head back and squeeze their nose closed in order to control a nosebleed. There's two problems with that, okay? What's the first problem? Cameron, do you know?
Is it because,
No, go ahead, Cameron.
All right, thank you. If you lean your head back, all the blood flow that comes from your nose will then go down through your throat and it could stop your breathing.
Potentially stop your breathing, but more more so, where is the fluid going to go if you swallow it?
Oh, down into the stomach.
And blood in the stomach blood doesn't belong in the stomach. So blood in the stomach can cause vomiting. So and then once the vomiting happens, then we have a risk of aspiration. Okay. So that's the first reason why we don't want to lean your head back to control a nosebleed. What's the second reason? Go ahead, Trey.
Well, you don't want to pinch your head and tilt your head back because that closes off the airway when you look up.
No, I mean, that's kind of a good guess, but remember when we were talking about opening up your airway and we said that if you get into sniffing position, it makes your airway more open?
Mm-hmm.
Okay, so it's a good guess thinking that it's because of the airway, but a sniffing position actually increases the space in your airway. The problem is that if you lean back, you can't tell when the nosebleed has stopped, right? Because nosebleeds are basically inside a cavity of your body. So if you're leaning back, you can't tell when the bleeding is done. So yeah. Okay. The nose often takes the brunt of physical assaults and car crashes because it's sticking out there. Doesn't matter how little you think your nose is still the furthest point out on your face. So if you are going to run into something, your nose is going to take the brunt of it. When you are assessing the nose or the structures in the nose for injury, it's helpful to picture the inside of the nose itself. We have our sinuses, we have our septum, we have all of our turbinates. You probably don't actually care. You probably just want to figure out how to stop the bleeding. If we suspect that we have a a basilar skull fracture, there's a possibility that we could have some CSF leakage through the nose or out the ears. Okay. How do we test and see if there's cerebrospinal fluid in our bleeding?
Halo effect.
Yes, we see if there's a halo effect. And explain that to me, please, Trey.
When you apply a gauze and there is bleeding, if there is a yellow ring that forms around the bleeding, that is it is likely CSF.
It is likely CSF, yes. And so if CSF is present, or you suspect that CSF is present, you can also suspect a basilar skull fracture.
What else could it be if it's only likely CSF?
Well, I say that it's likely CSF because as a field provider, you can give your field impression about what is wrong with a patient, but you can't make an actual diagnosis. So in this case, your field impression would be that they have a basilar skull fracture with cerebrospinal fluid drainage.
Okay.
Okay. If you were a physician and you were able to get the right scans, the CT scan or the X-ray or whatever, then you could confirm your field impression with a diagnosis.
Okay.
Okay, the ear is pretty complex, and it is associated with both hearing and balance. There are three parts to the ear. There is the external ear or the outer ear, the middle ear, and the inner ear. The external ear or the outer ear consists of the pinna and the external auditory canal, and it splits from the outer ear to the middle ear at the tympanic membrane. The middle ear is there's a canal in there, or not a canal, a cavity in there between the tympanic membrane and basically the oval window, and the bones, the hammer, the anvil, and the stirrup, or the incus, the malleus, and the stapes, those are inside the middle ear. And then the other part, the labyrinth and the cochlea, those are in your inner ear, and they're inside the bone, they're inside your mastoid bone. Ears are often injured, but they don't bleed very much. I actually went out on a call once where a guy had rolled his vehicle and had been ejected from his vehicle, and he was laying on the ground when we got out there. It was in the middle of the desert. He was laying on the ground when we got out there, and he wasn't super bloody or anything. We didn't really notice that there were any severe injuries until somebody went to take C-spine and realized his ear was missing. And then we went on a hunt for his ear. It wasn't bleeding really terribly, and we managed to find the ear and package it up and put it on the helicopter with him. But it was weird to me that like his entire ear had been ripped off, but there wasn't a ton of blood there. Your tympanic membrane, your eardrum, can rupture for a couple reasons. It can rupture from a change in pressure, like that from a blast or an explosion. It can rupture from people sticking things inside their ear. And again, clear fluid coming from their ear might indicate a basilar skull fracture. Facial fractures result from blunt impact, and you should assume that a direct blow to the mouth or nose has caused a facial fracture. If they have loose or movable bone fragments, guys, that's a pretty good indicator that they have a facial fracture. Your responsibility is to maintain their airway and make sure they can breathe. The thing about facial injuries is that the swelling can be incredibly severe. So often they may need to go to the emergency room, but often they won't be able to have surgery to repair those until the swelling goes down, 7 to 10 days-ish. Dental injuries can be very traumatic to the patient. Nobody wants to lose their teeth. And if necessary, you can apply direct pressure if necessary and your patient lets you. If a tooth comes out all the way down to the root, take it with them because sometimes those teeth can be implanted. Handle it by the crown rather than the root. Put it in sterile saline or milk. And if they can re-implant it within 20 minutes to an hour after the trauma. If you have an object impaled in their cheek, leave it there unless it's causing problems with their airway. The only time we would remove an impaled object if it's keeping them from breathing or if it's causing problems with their airway. That's the same story with let's say you have an impaled object in the back of the thorax, in the back of the chest wall. If you can't roll them over because of the impaled object, you have to get rid of the impaled object because you cannot maintain their airway or make sure that they're breathing appropriately if you can't get to the front of them. Injuries to the neck, all of those structures that we talked about a little bit ago, they're vulnerable to injury by blunt trauma. The thing about the cartilage, the thyroid cartilage and the cricoid cartilage and all of those C-shaped cartilaginous rings down your trachea is if those break or if those get crushed, your trachea doesn't have a way to maintain its shape. So if the cartilage breaks or if the cartilage gets crushed, there's a possibility that your trachea or your windpipe will be crushed. Yeah, that's what I just said. Once the cartilages of the upper airway, the larynx are fractured, they don't go back to their normal position. They're not supported by muscle to pull them back to where they belong. Some examples of things that can cause these blunt injuries are collision with a steering wheel, suicide by hanging, or clothesline injury while riding a bicycle. So keep that in mind if you come across those. Subcutaneous emphysema is a characteristic crackling sensation produced by the presence of air. That air gets under the surface of the skin, and then when you press on the skin, it feels like Rice Krispies underneath your fingers. Those Rice Krispies are dangerous. It means that there's air entering into portions of their body where it doesn't belong. Injuries to the carotid artery or the jugular veins can cause the body to bleed out. Or it can cause air to enter the circulatory system, again, which can lead to air embolism and cardiac arrest. If we have an injury that we suspect would allow air in, we're going to use an occlusive dressing, or in our classroom, they're tegaderms, and we're going to take that tegaderm and we're going to place it over the top of that injury so that we can prevent air from getting in. In this case, in the neck, we do not need to leave a corner up. There's no vacuum system in here. We do not need to leave a corner unattached. We need to tape the whole thing down. We can use Vaseline gauze. We absolutely can use Vaseline gauze to control that. We can put that Vaseline gauze and tape all 4 edges, but we have to control it somehow. We don't want air getting in there. When the larynx becomes crushed, it usually becomes crushed from the front and then it presses against the cervical spine. So instead of having this nice round shape like this, your larynx is then going to be like flat, or, you know, and the problem again with that is that the larynx doesn't go back to its normal shape on its own. There's no muscles or anything there to help protect it. Anything that is not interfering with the airway or interfering with breathing, if you have an impaled object and it is not interfering with the airway or it is not interfering with breathing, you need to leave it there because we can cause more damage on the way out. So our goal is to leave that there unless it's causing problems, because, you know, airway, breathing, circulation. These are the signs and symptoms of larynx injuries: respiratory distress, hoarseness, pain, difficulty swallowing, cyanosis, pale skin, sputum in the wound, subcutaneous emphysema, bruising, hematoma, bleeding. We want to apply cervical immobilization, but we don't want to use a rigid C-collar. So in this case, we might use towels or towel rolls to help stabilize the C-spine, because we need to make sure that we're not applying any extra pressure there that we don't need to apply. Now, if they're bleeding, obviously we're going to control bleeding with direct pressure. All right. Which of the following statements regarding the Adam's apple is false?
A.
Yeah, A.
A. The most obvious prominence in the center of the anterior neck is the Adam's apple. This prominence is the upper part of the larynx formed by the thyroid cartilage. It is more prominent in men than in women, although it is in both genders. The other portion of the larynx is the cricoid cartilage, and that's the firm ridge that's inferior to the thyroid cartilage. If you are ever asked to do a Selleck's maneuver for a paramedic who is intubating a patient, they want you to place your fingers on both sides of that cartilage and gently press down toward the patient's cervical spine. When you press down gently, super gently, it helps to bring their larynx in line with their vocal cords or with the opening to the larynx, so that your paramedic can see where they are sending that endotracheal tube. Okay. The globe of the lens is also called the
Globe of the eye is also called.
Yeah, I'm sorry. The globe of the eye is also called the
Eyeball.
eyeball. When a person is looking at an object up close, the pupils should
Constrict.
It's called pupillary accommodation, and they occur almost instantaneously, and unless you're paying attention to them, you'll never see them. By the way, this is not correct. That's this is where I got that idea. Tell me why the quizzes are not correct. When caring for a chemical burn to the eye, the EMT should
A.
direct the stream away from the uninjured eye. Which of the following signs is least indicative of a head injury?
B.
B. What's the purpose of the eustachian tube? What is the eustachian tube?
Is that from the ear to the
Throat, yep.
throat? So that'd be C.
When caring for a patient with facial trauma, the EMT should be most concerned with
Airway
compromise.
airway compromise. No airway, no patient. By the way, have you guys been paying attention to the articles coming out of New York and New York Fire Department EMS? Because they're talking about how they are not transporting people who are who have coded, and people are all up in arms because they're not transporting people who have coded, but we haven't transported people who have coded in years, and it's been that way nationwide, even in New York, because it's very difficult to perform CPR correctly and effectively in the back of an ambulance. People have a better chance of survival if they get a return of spontaneous circulation on scene than they do if we try and transport them to a hospital. Anyway, I just thought it was interesting.
Yeah, and because in our textbook it says if nobody dies or multiplies in the back of an ambulance.
Right. Miss Mack says that.
Mm-hmm.
Yeah.
But the textbook, it told us stop the ambulance, start CPR, apply an AED, and
Absolutely. Absolutely. Because that's how it should be. Oh, there you go. The answer's C.
C again.
Or would that be A?
What's the difference between C and A?
It's the dressing.
It's the type of dressing, yeah. A says apply a pressure dressing to his neck. We can't apply a pressure dressing to his neck because a pressure dressing is a circumferential dressing that applies pressure, right? We can't do that on the neck because we're going to wind up closing that airway.
Okay.
If this had said apply direct pressure to the wound on his neck, that would be correct.
A.
A. Okay, so that is the end of that lecture. Do you guys have any questions? I opened the quiz that was due yesterday at midnight. I opened it this morning at 9 o'clock. You guys are all on your computer. Will one of you please log in and just double check and make sure that it's open and that it will be, it's scheduled to close tomorrow at midnight. And again, if it happens again that you guys don't have access to those quizzes, I need you to send me a reminder or something and let me know. It's the chapter 25 quiz, Trey.
Oh, chapter 25. Yes,
Yep.
that makes more sense.
I don't see chapter 25, I only see chapter 24, and that one is still not saying that it's open.
Well, chapter 24 should be done and closed already. It was closed yesterday.
Yeah, it is closed.
I just don't see 25.
Okay, let me look here because I have it right there.
Yeah, I'm not seeing 25 either.
Okay, that's too bad because right here it says submissions enabled. So let me see where I'm screwed up at. Edit. 4:14. Save changes.
Because it might be enabled, but we just can't see it.
All right, try again.
Yep.
Okay, so that is due tomorrow night then. Tomorrow night at midnight. Your 26 and 27 case studies are due on Friday, and I will get your 26 and 27 quizzes loaded and published so that those can be due on Sunday. Also, I am going to put an assignment in there for next week for your egg skull fractures.
Egg skull fracture.
Yep, those are fun. You guys will have a good time with them. They're easy, lighthearted. Any questions about the expectations for the upcoming week?
No.
No?
Yeah.
No.
But going over that neck and facial injury PowerPoint, I can understand why Michael is so afraid of people touching his neck and all the different injuries and things.
Well, to be completely fair, there are, you can have injuries to any part of your body. So, but yes, the neck, especially because it's not protected, is susceptible.
Right. Also, touching people's necks is a weird thing to do. So it's kind of understandable why he wouldn't want you touching his neck.
It is not weird. Okay, imagine this.
Wait, before we start imagining, I just have to tell you that I agree that touching the neck is weird.
Okay, but what if I'm oh, hey bud, how's it going? Pat. Oh,
Do you
look at that. My
pat
hand's their
people on the
shoulder
back of the neck?
and their neck.
You pat
That's not
people
weird.
on their neck?
Well, it just happens to be on the neck, and that's not weird.
No, that is.
It's weird.
If it was the upper back and getting a pat, that's one thing, that's fine. Not the neck.
All right. Any other questions about the week before we get off the Zoom?
Are you going to post the entire lecture to do notes again?
I'm sorry?
Because I like, whenever you do lectures in class, I like being able to listen and then make notes on what you're saying, and then go back and take notes on what was written. Are you going to post this one on YouTube like you did the last one?
Yes, every Zoom that we have from now until the end of the year, if we continue to have Zooms, because if people don't show up, I'm not going to continue to have Zooms. I'll just be by my phone for an hour. But every Zoom we have from now until the end of the year will go on my YouTube channel, and then I will post the link in Schoology.
Okay.
Okay. By the way, Jeff and me and the instructor from Nampa, we're going to go to school tomorrow afternoon to do the videos for your skills.
Awesome.
Okay. All right. Anything else?
Are you going to make sure to get multiple camera angles? And
No.
Oh.
Nope. You get one camera angle, you get one recording, that's it. We have 10 skills we have to do in a fairly limited amount of time, so you get what you get and you don't throw a fit. All right. Any other questions? Okay. I will post those links as soon as I get them edited for YouTube. Have a good day. Enjoy your week.
Thank you.
Bye. Oh, wait, one more thing. Sorry, I didn't end the meeting yet. One more thing. The best way for you to get a hold of me is not via email. The best way for you to get a hold of me is through Remind. You can send me a message directly through the Remind app. If you send me a message after 3 o'clock, I will likely not answer it until the following school day. Unless it's about your quizzes, in which case I'll open your quizzes because we can't afford to fall behind. Okay?
Yeah.
All right.
We all assumed that it was just that we were going to take it next week or something, or yeah.
All right. Have a good day, guys.
Thank
Thank you.
Bye.